Welcome dear students. In this video, let us learn about the management of Meniere's disease, investigation and treatment part. So first about investigations. After the clinical examination, the investigations that we perform are, first is a pure tone audiometry to assess the hearing loss. As we already know, Meniere's disease produces sensorineural type of hearing loss. So the results of pure tone audiometry would also show the same. There is sensorineural type of hearing loss. Now in the initial stages of the disease, the low frequencies are affected. Now you already know that in the basilar membrane, towards the apex of the cochlea, low frequencies are heard, and at the base, high frequencies are heard. So it is usually the apex part that is initially destroyed. So the low frequencies are affected first. Low frequencies are affected and the high frequencies are normal. So how does the graph look like? It looks like this. The low frequencies show hearing loss and the high frequencies are normal. The hearing improves as we go towards high frequencies, and this is called as an upslope or a rising curve. This is observed in the initial early phase of the disease. Later on, even the high frequencies are affected. When the high frequencies and low frequencies both are affected, we observe a flat type of graph. And even later, a downslope is observed. This is at later stages when the high frequencies are also affected. This is the most important feature of pure tone audiometry. Next, we do a speech audiometry. When a speech audiometry is performed, the speech discrimination score is usually normal and nice in between the attacks, but is very much impaired during an attack. In between, it is around 55 to 85%. In between attacks. And it is low during an attack. As such, sensorineural hearing loss would have a poor speech discrimination score. And then a few special tests are done. Special audiometry tests. To distinguish between a cochlear versus retrocochlear type of lesion, these tests are done. Now, retrocochlear lesion could involve the 8th nerve or the auditory cortex also. Anywhere through that entire path beyond the cochlea, whatever is affected is called as retrocochlear disease. Now, we are trying to distinguish between a cochlear versus a retrocochlear disease. Meniere's disease, as you already know, is cochlear type. Okay, so the features that are observed are, recruitment test is positive. We learnt about this in clinical features also. Recruitment phenomenon leads to intolerance towards loud sounds. SISI score is very good. What is SISI? Short increment sensitivity index. Normally, for a normal person with normal hearing, the SISI score is usually around 15%. But in these patients, in patients with cochlear type of hearing loss, their SISI score is very, very good. It's usually around 70%. SISI score is good. In normal people, it is only 15%. A tone is taken and at small intensities, 5 decibels or even less than that, sound is increased. And a normal person cannot appreciate that small change in the sound, whereas a cochlear type of hearing loss person can observe those changes. So they have a good SISI score, a high SISI score I can say rather. And then we do something called as tone decay test. Normally, there is decay of less than 20 decibels. This is tone decay test. We have learnt about all these tests in detail in the assessment of hearing. So these are the features that are found in Meniere's disease in special audiometry tests. And then there is one more very important test called as electrocochleography. This test is very sensitive and it is diagnostic of Meniere's disease. What is shown in electrocochleography is, in the cochlear micropotentials, we have studied that there are two types of potentials, the summating potential as well as the action potential. Summating potential and action potential. Normally, summating potential is to action potential ratio in normal people. It is around 30%, whereas in a patient with Meniere's disease, this increases. It is usually more than 50%. This is classically seen in Meniere's disease, and if at all this finding is given in the exam, the examiner is straightly pointing towards Meniere's disease without any confusion, and it is diagnostic of Meniere's disease. Then we have a few other small tests such as the caloric test. Caloric test is a test done to assess the vestibular function. We instill cold or hot water and induce nystagmus in the patient. That is broadly caloric test. And when the vestibule is affected, definitely caloric test would show a reduced response. So there is reduced response on the affected side. In at least most of the cases, 75% of the cases, they show reduced response on caloric test. Now the results of caloric test are studied usually under two headings. One is called as a canal paresis. Canal paresis means a reduced effect on the affected side. So in Meniere's disease, this canal paresis is observed on the ipsilateral side of the lesion. Whichever ear is affected, that side there is reduced response. And there is something else called as directional preponderance. Directional preponderance. Now these are used to distinguish a central lesion versus a peripheral lesion while studying vestibular pathology. So directional preponderance is towards the healthy side. So it is towards the contralateral healthy side. So we observe ipsilateral canal paralysis and contralateral directional preponderance, and sometimes both of them are also observed. So there is canal paresis on the affected side and directional preponderance towards the healthy side. This is about caloric test. Next in our list is glycerol test. Glycerol is a dehydrating agent. It absorbs water, it draws away water. So when glycerol is given orally, it acts all through the body and the endolymphatic pressure is reduced. Why? Because the endolymphatic sac volume, endolymph volume reduces, and so automatically the endolymph pressure also reduces. So this is not just a diagnostic test, it also has some prognostic value, because the moment the endolymph volume and pressure drop down, the patient will experience a great relief in symptoms. So what we do? We take some amount of glycerin, mix it with water, equal amount of water. How much glycerin do we take? 1.5 ml per kg body weight. And an equal amount of water is taken. Both of them are mixed, and to facilitate drinking by the patient, we add some flavor or some lime juice to it and make the patient drink that. And after that, what we do is we take an audiogram and a speech audiometry is done. We do an audiogram, pure tone audiometry, and also speech audiometry is done. after consuming glycerol. What we find is the scores have improved. There is a good improvement that is seen in both these scores. 1 to 2 hours after taking glycerol, we do these two tests and we find that there is a good improvement in the score. How much improvement? At least 10 decibels in audiogram, 10 decibels difference between the two tests, and a speech discrimination score more than 10% improvement is observed. This shows that the test is positive and it is Meniere's disease. And subjectively also, if you ask the patient says there is improvement in his tinnitus and also there is relief from that sense of fullness of ear that is usually experienced by the patient. So glycerol test is both diagnostic as well as prognostic. But electrocochleography is still the most specific and sensitive test to diagnose Meniere's disease. It's combined with glycerol test, and these two tests together usually give us a diagnosis of Meniere's disease. Now there are a few variants of Meniere's disease that you need to understand. They're very similar to Meniere's disease, but also there are some differences. So they are studied as variants of Meniere's. And the first variant is called as cochlear hydrops. What is cochlear hydrops? Only cochlear symptoms of Meniere's disease are present. Vertigo is seen many years later. So cochlear hydrops after a few years, many years can progress to Meniere's disease. There is blockage of the ductus reunions. So this leads to high pressure only in the cochlear duct part of the endolymphatic system. The rest of the system is fine. So only cochlear symptoms are seen. Only cochlear symptoms are seen. Vertigo also develops years later. The second variant is vestibular hydrops. In this, patient gets those typical episodes of vertigo, but the cochlear function is absolutely normal. That is vestibular type of hydrops. So vertigo is present, but no cochlear symptoms. In normal Meniere's disease, we see all four cardinal features: vertigo, hearing loss, tinnitus, plus sense of fullness. So in vestibular hydrops, only vertigo is present. And in these patients of vestibular hydrops, if at all a surgery is done, endolymphatic hydrops could not be demonstrated in them. The endolymphatic sac and other structures are usually normal. Then there is another variant which is called as drop attacks. This has another name also, that is Tomarkin's otolytic crisis. What happens in Tomarkin's otolytic crisis or drop attacks is that the patient suddenly drops down without any loss of consciousness. There is no vertigo, there is no fluctuating type of hearing loss, there is no tinnitus, nothing. Suddenly the patient is, until then the patient is absolutely normal, and suddenly the patient falls to the ground as if somebody has pushed the patient or somebody has thrown him down onto the ground, and he is fully conscious when this is happening. So this is called as a drop attack. It's an uncommon manifestation of Meniere's disease, and it can occur either in the early stage of the disease or sometimes in very late course of the disease. And the possible mechanism is maybe there is some deformation of the otolytic membrane of the utricle or saccule. Because of all this excess volume of endolymph and the high pressure of endolymph, that sensitive otolytic membrane of the utricle or saccule is getting damaged, and it is leading to dropping down of the person, and that is why we call it otolytic crisis. It happens all of a sudden, that is drop attacks. Patient drops or falls to the ground while being fully conscious. Now, most of the times, even the patient cannot explain how he or she fell down. There is no vertigo. There is no hearing loss also. This is drop attacks. And then we have the last variant, which is called as Menieres syndrome. And this is followed by an attack of vertigo. And then the hearing recovers. In normal Meniere's disease, what happens is, first there is vertigo. During vertigo, there is hearing loss, and then vertigo will also subside and hearing will improve. But in Meniere's syndrome, what is happening is, first there is hearing loss and then vertigo will occur. With the occurrence of vertigo, hearing improves. So, vertigo improves hearing. There in normal Meniere's, vertigo will deteriorate hearing. During the episode of vertigo, there is deterioration of hearing. That is the main difference between Meniere's versus Meniere's syndrome. And now, there is another terminology that you need to understand, that is Meniere's disease versus Meniere's syndrome. What is the difference between Meniere's disease and Meniere's syndrome? Now, Meniere's disease is idiopathic. We just have a few theories that are explaining, but why each of them are occurring also we do not know. We know that it is because of some defective absorption of endolymph, but why is defective absorption occurring? We do not know. Or we know that it is because of increased production of endolymph, but why is that happening? We do not know. So, Meniere's disease is idiopathic. But sometimes there will be known causes which are leading to this excess production of endolymph, and then it is called as Meniere's syndrome. So, distension of endolymphatic system is occurring secondary to some cause, and then it is also called as secondary Meniere's disease. Now, whenever we have primary and secondary forms of any disease, primary is always idiopathic and secondary is because of a known cause. Primary hypertension is idiopathic. Secondary hypertension, primary hypertension is idiopathic. Secondary hypertension, there is a cause known to it. Okay. So, similarly here, Meniere's disease, primary disease is idiopathic. Secondary Meniere's disease, also called as Meniere's syndrome, there is some known cause to it. Let us see what are the known causes. Maybe there was a history of head trauma, injury to the inner ear, following an ear surgery. A surgery was performed for some other reason, and after that some structure was destroyed, and that led to all these conditions. And even as a complication of some viral infections like measles or mumps. Measles or mumps. And sometimes it can occur following syphilis also, either congenital syphilis or acquired syphilis. So, when a known cause is present, it's called as Meniere's syndrome. And then there is one more concept that you need to understand, that is staging of Meniere's disease. How do we stage Meniere's disease? After the diagnosis of Meniere's disease has been confirmed, then we go to staging. We perform pure tone audiometries for a period of time for 6 months and take the reports of the worst audiometry result. And stage 1 is said to be present when the hearing loss is less than or equal to 25 decibels. The pure tone average. and it is said to be in stage 2 when the loss is between 26 to 40 decibels. Stage 3 from 41 to 70 decibels, and after 70 decibels it is stage 4. Now the staging is important because this will sometimes decide our treatment. Based on the hearing loss the patient is undergoing, we devise various methods of treatment. So with this I complete the investigations part of Meniere's disease. Now let us look into the treatment of Meniere's disease. Now in any disease whose etiology is not clearly known, treatment is somewhat blind. We are trying various measures. Basically we are trying for a symptom relief, but addressing the true cause is very difficult, and the same goes with Meniere's disease also. The treatment of Meniere's disease can be studied under 3 headings. One is the general measures that the patient has to take after he has been diagnosed as a case of Meniere's disease. And second is during an acute attack when the patient comes to you, what you have to do. And third is what are the chronic measures. In a chronic patient of Meniere's disease, what treatment has to be given. That is mostly to prevent further attacks. Okay. So first let us study about the general measures. Now to begin with, counseling of the patient is very important. As I told you, the first attack of vertigo or any attack of vertigo for that matter is a very scary experience to the patient. So we have to try to explain him about the nature of the disease, what exactly is happening, and reassure him that it's okay, because sometimes patients actually see it as a life-threatening experience. So we have to counsel them about when that could happen and what the patient should do during such attack. So this will relieve the patient's anxiety first, and after reassurance and patient counseling, there are some lifestyle changes that the patient needs to follow that could help. Now the new age rule is that lifestyle changes help almost every disease. A good healthy lifestyle is always healthy, and it subtly helps in addressing so many problems. So a good healthy lifestyle should always be encouraged, and the first in this is cessation of smoking. Cessation of smoking is very important because nicotine causes vasospasm, and vasospasm will aggravate the condition. We have also learned in the theories of etiology that increased sympathetic activity and vasospasm of the internal auditory artery and its branches is leading to this problem. So nicotine will further aggravate that problem, and so complete smoking cessation is very important. And you will be surprised to know that in some patients that is the only treatment. They stop smoking and they are completely relieved of Meniere's disease. So it's very important that you ask the patient about his smoking history and counsel accordingly. Next is a low salt diet. Because salt and water retention is also known to be one of the etiology, so a low salt diet is always recommended, and the patient should try to remain salt free as far as possible, and extra salt should definitely not be taken, and the goal is around 1 to 2 grams per day, not more than that. Next is excess water intake should be avoided. Now this has to be carefully explained to the patient, because generally people believe drinking lots and lots of water is a healthy habit. But no, avoiding excess water is important, because this water retention could lead to increased filtration at the level of stria vascularis and increase the endolymph production. Next is avoidance of excess tea, coffee and alcohol. Avoid excess tea, coffee and alcohol, because these can stimulate the sympathetic system and aggravate the condition. And most important is to avoid any form of stress. The patient should practice mental relaxation techniques like yoga, meditation, doing some physical exercise and all those things, and that will also help. Okay. And another very important advice is, you should ask the patient about his occupation, and if at all he is involved in some activities such as flying, underwater diving, or working at huge heights, all of them are prohibited. In fact, they could be dangerous to the patient, because suddenly at that point, if the patient experiences an episode of vertigo, now generally patients of vertigo do not fall to the ground. Say the patient is a construction worker working at a huge height and is in an already vulnerable position, their experiencing vertigo could be very, very dangerous, and maintaining that balance could also be all the more dangerous. And if the patient is a pilot, it's all the more dangerous, not just to his life, but to the entire crew of the flight. So they should not be in such dangerous occupations. Occupation of the patient is important. And no important or crucial or dangerous occupation to be taken up by the patient. So flying a plane or being a construction worker, that too at huge heights, or ascending to heights for any other purpose, these are all a strict no-no for the patient. That is for the safety of the patient. You have to explain that to the patient, because accidents can happen if at all there is a sudden episode, because not everybody gets a warning sign, okay? So these are the general measures: reassurance, lifestyle changes, and occupational rehabilitation, if at all the patient is involved in such occupations. Second is, when the patient comes to you during an acute attack, what will you do? The patient is suddenly experiencing vertigo and he has come to the hospital. What will you do? Again, you have to reassure him and try to make the patient feel better, remove his anxiety, and bed rest is essential here. Bed rest to the patient. The patient should be avoided to move and travel here and there. And also, the head should be supported on pillows to prevent excessive movement of the head. Because even if there is some otolytic crisis, that can also aggravate vertigo. So bed rest with the head adequately rested on a pillow. And then these patients usually have vomitings along with vertigo. So we have to give IV fluids plus electrolytic agents. Why? Vomitings, excess vomitings especially, can disturb the electrolytic balance of the body. It can also lead to dehydrations. So IV fluid and electrolyte administration are very important. Then vestibular sedatives have to be given. This is the main part of the treatment that is done to address the attack of vertigo. Vestibular sedatives will subside vertigo. They have to be given as an intramuscular injection, and if at all the patient is not having vomitings, even orally also the drug can be given. So the drugs that are usually given during acute episodes are prochlorperazine. Prochlorperazine is commonly used. And dimenhydrate and promethazine thioclate, it's under the brand name of Evomine. Promethazine, dimenhydrinate, all these drugs are usually prescribed. And even diazepam can be given actually. Diazepam will sedate the patient and it has a tranquilizing effect. So the patient will go to sleep and feel much better after waking up. Plus diazepam will also suppress the medial vestibular nucleus. Okay. Even atropine is used in some cases. A subcutaneous injection of atropine is given and that will also subside the effect. Plus, along with these, we also use vasodilators. Vasodilators will produce some relief. So, some vasodilators that are usually used are inhalation of carbogen, which is a cerebral vasodilator. So, this will improve the labyrinthine circulation. IV histamine diphosphate is also used. This drug should not be used in asthmatics and also on empty stomach. It's strictly contraindicated in asthmatics, but it helps in managing an acute episode. Okay, even beta histine is used. Beta histine is also a vasodilator. It will dilate capillaries, arterioles, and even arteriovenous arcades of the stria vascularis. So, this will lower the endolymphatic pressure. The adverse effects of all vasodilators is that they cause tachycardia and disturb the cardiac rhythm, and sometimes they may lead to hypotension, hyperthermia, and bronchospasm. So, the adverse effects of vasodilators are tachycardia, hypotension. These you must remember because they're basically disturbing the cardiac rhythm. So, these drugs have to be used in caution. So, when the patient comes to the hospital during an acute attack, first bed rest is important, and then vestibular sedatives will improve the condition of the patient, and diazepam can also be used along with vasodilators. Vasodilators will relieve the vasospasm, and that will automatically improve the symptoms. And then in the chronic phase, what is the advice that has to be given to the patient? How do we treat a patient whose a known case of Meniere's disease has had episodes of acute attacks and now is in the chronic phase? So, this part of treatment is also like the general treatment only. Dietary modifications are suggested, such as salt restriction and reduced water intake. Intermittent dehydration has to be started. Along with that, diuretics are used. Now, general measures did not constitute any pharmacological therapy, but here I am discussing a few medicines that are used in these patients. Diuretics can be used. For example, we use furosemide, a loop diuretic. Furosemide is always used along with potassium supplements because furosemide can deplete the potassium stores of the body. So, furosemide plus potassium supplement on alternate days if we take, it will help to control the recurrence of attacks. If the recurrence is not controlled by vasodilators or vestibular sedatives, then we can go for diuretics which will control the recurrence of attacks. Not just furosemide, we can even use thiazide diuretics, which are potassium sparing. Thiazide diuretics. Acetazolamide can also be used. And again coming back to vasodilators. Vasodilators are used during an acute attack, and otherwise chronically also we can prescribe vasodilators so that vasospasm doesn't occur in the first place. So same, histamine, beta histine, all of them can be used. But as you know, vasodilators do have some side effects, so they have to be used consciously, weighing the pros and cons. And then some symptomatic treatment is essential for the patient, because these patients are experiencing vertigo, some anti-vertigo drugs, and they also have vomitings during such episodes, so antiemetics. Sedatives and tranquilizers in mild doses. And if required, even antidepressants are sometimes used. Psychiatric treatment is essential as a supportive part of therapy. Next, there is another drug called as propanthelene bromide. Propanthelene bromide. Let us see what this propanthelene bromide does. It is used thrice a day, either alone or in combination with a vasodilator. And this is found to be effective in some cases. But many do not use it because of the side effects. Actually, this propanthelene bromide is an antimuscarinic agent. Antimuscarinic drug. Now, as I told you, when the etiology is not clear, treatment mostly goes like this. You're trying multiple things just in the hope that something works. And also again, there are some general measures to be taken by the patient, such as we know that this could be because of allergy. So control of allergy is very, very important. Identifying the allergen and try not to get exposed to that allergen. If at all that's not possible, at least anti-allergy treatment has to be given to the patient. And if at all, if it is because of hypothyroidism or some other hormonal problem like that, that has to be addressed. And as I told you, just treating hypothyroidism itself will cause complete relief of the symptoms of Meniere's disease in patients. Okay. Along with these, there are some other modes of treatment also, such as a Menieres device. Repeat. Along with these, there are some other modes of treatment also, such as Menieres device and even surgical treatments. So when all this medical therapy fails, then we go for surgical treatment. So in surgical treatment, we have something called as chemical labyrinthectomy. What is chemical labyrinthectomy? It is used in patients where vertigo is very, very disabling. It's affecting their quality of life and the patient is experiencing vertigo all the time, not able to perform any function in life. Then this chemical labyrinthectomy is done. And also that vertigo is refractive to medical treatment. So what we do in chemical labyrinthectomy is we intentionally administer vestibulotoxic drugs. Ototoxic drugs. What are they? Streptomycin, gentamicin. We take a solution of gentamicin and we inject it directly into the middle ear at the round window. And then through the round window, it will go into the inner ear and do its job. Through the tympanic membrane, this injection is made in the posterior inferior quadrant of tympanic membrane with a needle. A 25 gauge needle usually. The needle is sent inside into the middle ear and at the round window it is injected. Around 0.5 cc solution of gentamicin is used. And after 30 minutes, for 30 minutes the patient lies in that position, in the supine position, and with the head turned away from the treatment ear. And these injections are repeated for a few weeks until the treatment is effective. So the inner ear is perfused with a vestibulotoxic drug. This is chemical labyrinthectomy. It's not exactly a surgical type of treatment. Now let us discuss about the core surgeries that are performed. And I can study them under two headings. There are two types of surgeries. One is hearing conservative surgeries. And the second is non-hearing conservative surgeries. Basically, in the first type, the hearing is preserved, and in the second category, the hearing of the patient is not preserved. When do we do hearing non-conservative surgeries? When the hearing loss of the patient is already very, very profound, or there is no possibility of doing hearing conservative surgeries, and the patient's life is so disabling because of vertigo that treating vertigo becomes more important than preserving hearing also. Okay, so let us discuss both the categories. And in hearing conservative also we have two types. They are non-vestibular ablative surgery, and the second category is vestibular ablative surgery. Let us study about all of them in a little more detail. So first category is non-vestibular ablative surgery, and this is hearing conservative. Hearing conservative non-vestibular ablative type of surgery. The first under this category is endolymphatic sac decompression. Endolymphatic sac decompression. What we do in this? We go to the endolymphatic sac and decompress it, remove all the excess endolymph fluid that is present. But this fluid can reaccumulate again. So we offer a permanent solution. We insert a one-way valve and the drainage pathway of the endolymph is rerouted directly into the epidural space by incising the back part of the sac. The posterior wall of the sac is incised so that this endolymphatic fluid now directly joins into the epidural space, and a one-way valve is placed. A valve could be placed, or a stent could be placed, sometimes a silicone tube is placed. Various substances are placed, and reaccumulation of the endolymph does not occur. Another thing under this category is cochleosacculotomy. Cochleosacculotomy is done when there is some mechanical blockage either in the utricular or saccular ducts, and this is not allowing the endolymph to reach the endolymphatic duct and sac. So then what we do is we perforate the saccule behind the oval window and remove all the fluid. That is cochleosacculotomy. And then even transtympanic corticosteroid infusion of the middle ear is also done. These are the hearing conservative non-ablative surgeries. In the next category we have ablative type of surgeries. These are also hearing conservative only. Hearing conservative vestibular ablative surgeries. First among them is vestibular neurectomy. As the name itself suggests, the vestibular nerve is resected either via middle fossa approach or a suboccipital approach or a retrostigmoid approach. We approach the vestibular nerve and resect it. And about 95% of the patients have complete resolution of vertigo after this surgery, and also their hearing is preserved. That is the advantage of vestibular neurectomy. Even cryosurgery and ultrasonic destruction of the vestibular labyrinth have been tried. Ultrasonic destruction of vestibular labyrinth. In these procedures also the cochlear function is preserved, so cochlea is normal. In the next category, now let us move on to non-hearing conservative surgeries. Non-hearing conservative vestibular ablative surgery. The first surgery under this category is labyrinthectomy. When serviceable hearing is absent and the pure tone average is more than 60 decibels and speech discrimination score is less than 50%, then labyrinthectomy can be done. In labyrinthectomy, hearing is not preserved. The membranous labyrinth is completely destroyed. The entire membranous labyrinth, cochlea, the hair cells of cochlea which are present on the basilar membrane organ of Corti is also completely destroyed. The entire labyrinth is destroyed. You either open through the semicircular canals by a transmastoid route or through the oval window by a transcanal approach. But this will give complete relief from the attacks of vertigo. How do we perform this ablation? By using hypertonic saline. Or a translabyrinthine cochleovestibular neurectomy is done. Translabyrinthine cochleovestibular neurectomy. If only vestibular neurectomy is done, it is hearing conservative. If cochleovestibular neurectomy is done, it is non-hearing conservative. Then destruction of Scarpa's ganglion. This is a ganglion of the 8th nerve that is present in the internal auditory canal, and this ganglion is destroyed. All of these will lead to relief of vertigo, but hearing is destroyed. Now, one last thing that you need to know is about Meniere's disease, Meniere device therapy. This is used when medical treatment has failed and surgeries are being considered. This Meniere device therapy is also called as intermittent low pressure pulse therapy. Now, what is this intermittent low pressure pulse therapy? Positive pressure is intermittently delivered to the inner ear fluids, and this will bring about relief from the symptoms of Meniere's disease. How does this occur? When positive pressure waves are delivered through an instrument, that instrument is called as Meniere's disease. Okay, so when these positive pressures waves are delivered into the inner ear fluid, there is a readjustment, redistribution of the endolymph through the various channels that are present. Now, there is excess fluid. Say, suppose it's like a distended balloon that's full of tension, and you tapping it with some pressure will readjust and redistribute the fluids that are present, and sometimes it could get drained away also. And this will provide a relief in symptoms. So, that is the idea behind Meniere's disease. There will be relief of vertigo, relief with tinnitus, and hearing will also improve, and that ear fullness experienced by the patient, all of them will come down. But usually it is a transient relief. Later on again, this comes back. How long the effect lasts is not very certain. Now, how do you do this? A myringotomy is performed first. A small incision is made in the tympanic membrane and a ventilation tube is inserted into that. And this device is coupled to the external ear canal, and then it delivers pressure waves. And these pressure waves via the ventilation tube will go into the middle ear and directly go to the round window membrane via the ventilation tube. Now, the ventilation tube extends till the round window membrane. And these positive pressure waves will pass through the perilymph and cause a reduction in the endolymph pressure by redistributing the endolymph through the various communication channels that are present. Self-administration of this treatment can be done at home by the patient also. And sometimes after a few months, there will be complete remission of the disease. So this device is useful for patients who have failed medical treatment and surgical treatment is also not possible in them for some reason. Their Meniere's device is an excellent treatment option. So what is the principle of Meniere device therapy? It is intermittent low pressure pulse therapy. So, positive pressure waves. Positive pressure waves are sent into the inner ear fluids and they cause redistribution of the endolymph and lead to relief of symptoms. This is the idea of Meniere's disease, and with this I complete Meniere's disease. It is slightly a complex disease process. Nevertheless, it can be understood once and forever if you pay little attention to it. The etiology is not very clear, and the main pathophysiology is there is distension of the endolymphatic system that is responsible for all the symptoms. The cardinal 4 symptoms are vertigo, episodic vertigo, fluctuating hearing loss, tinnitus, and a sense of fullness in the ear. Coming to the diagnostic features, pure tone audiometry shows sensorineural type of hearing loss, and some special audiometric tests are done to distinguish a cochlear lesion from a retrocochlear lesion, and Meniere's disease shows all the features of a cochlear type of hearing loss. Speech discrimination score is poor, and electrocochleography is very characteristic in showing a rise in the summation potential is to action potential ratio. Along with that, caloric tests and glycerol tests are also done, which lead us towards the diagnosis. And treatment consists of medical treatment as well as surgical treatment, and Meniere's disease is present in between. Medical treatment is the general lifestyle measures that have to be taken and some preventive measures. Plus, during an attack, what we have to do is give vestibular sedatives and relieve the anxiety of the patient, and vasodilators have to be given. In chronic phase, diuretics along with vasodilators are used. If all these medical treatments fail, then the patient is put on a device called as Meniere's device, which works on the principle of intermittent low pressure pulse therapy. Positive pressure waves are sent into the inner ear fluids, and that will provide relief of symptoms. And the surgical measures can be divided into hearing conservative and non-hearing conservative. In hearing conservative, we again have two types, vestibular ablative and non-vestibular ablative. And in non-hearing conservative, there is one type, non-hearing conservative vestibular ablative type. In that, labyrinthectomy is done. Translabyrinthine cochleovestibular neurectomy is another method, plus destruction of Scarpa's ganglion is done. Scarpa's ganglion is a ganglion of the 8th nerve that is present in the internal auditory canal. So these are the three measures out of which labyrinthectomy is usually done. And apart from this, chemical labyrinthectomy is also being tried recently. It has become popular recently, and chemical labyrinthectomy is about destroying the labyrinth by injecting vestibulotoxic drugs such as streptomycin and gentamicin into the inner ear. So this is about Meniere's disease. Thank you very much.